Okay. Thank you very much indeed, Christina.
Hello, George from Athens.
Hi, welcome. Thank you very much for inviting me to present. I'm dreadfully sorry that I'm not able to be with you personally today, but I'm putting up with the very cold weather here in Scotland.
We have 20 degrees today.
Oh no. Well, hopefully I will brighten up your afternoon even more by this presentation. What I would like to do is I'd like to share with you the world that I inhabit in Scotland, and my challenge to colleagues in the audience is to take the key messages and fit them into your own health and care environment in Greece, because I firmly believe that everything I'm going to talk about today from my perspective is going to be very familiar and equally relevant to you. So what I'm not going to do is I'm not going to tell you that everything is absolutely wonderful in the world, because it's not. I'm going to actually share with you the fact that things are, if anything, very difficult for us all, particularly those who are tasked with either managing or delivering health and care services. The key issue for us is, as you will have talked about earlier, our aging society, the increase in long-term conditions. We can celebrate the fact that everyone is living longer, but the challenge is, are we living healthy life years? Or are the last 4 or 5 years we spend on earth confined to increasing frailty and disability and dependency? In Scotland, we have challenges with lack of certain healthcare professionals. I don't know what it's like in Greece. I know that you've got an oversupply of doctors at the moment, but we tend to go through periods where we've got too many nurses or too many doctors, and then in 3 and 4 years, because we turn down the supply, we have too few. And we're not very good at workforce planning. We have challenges between the rich and the poor as far as health inequalities are concerned. And of course, irrespective of where you are in Europe, we all have financial challenges. Luckily, from our point of view, not quite as acute and damaging as that we've had in Greece, but it is good to hear that things are beginning to move forward. But let us now take all of this into our own world. Let's look at the issues that we all face. Across the whole of healthcare, wherever you are in the world, there is an increasing demand on our services. The challenge is the way we deliver our services are unsustainable into the medium and long term, because certainly public service workers in Scotland tend to be some of the best paid or have the best terms and conditions of employment of anyone in Scotland, and that is a problem for us. But we also have this issue where we have to recognise that the vast majority of healthcare is provided not by the public sector themselves, but by informal carers. And this is a patient of a gentleman who was a senior policeman and who had a major stroke, and most of his care is provided by his wife with minimal support from the health and care system. And we are aware if people like this lady walked away from that responsibility, our health and care system could not cope. I don't know if anyone in the room will recognise this building. I would suspect you won't, but this is our brand new hospital in Scotland. It's the Queen Elizabeth II Hospital in Glasgow, and strangely enough the local population call it the Death Star, which is not a good name for a hospital, but they called it that because it looks a bit like the Death Star in Star Wars. But this hospital cost over €1 billion to build. And the reality is that it is not going to solve any of the major health and care problems we have in Scotland. Because where is the battlefield for us? It's not in our hospitals, although our newspapers tend to concentrate on hospital care. Our politicians tend to focus on hospitals. Even the citizens tend to think about hospitals when we talk about healthcare. But the vast majority of people live their lives in the community and manage their health and care challenges in the community. And we have to start thinking about how we are going to move care from high-cost hospital settings into community settings where people live their lives. So in Scotland, this is the vision for the health service. And this will be very similar to the aspirations that you have and colleagues have across Europe. What we say is everyone should live longer, healthier lives at home. We're going to deliver that by integrating health and social care. We're going to focus on prevention, on anticipation and supported self-management. And if you do need to go to hospital, it will be for as short a time as you need to be there, and then we will look to get you back home or into a homely setting. Now, a year ago, our government recognised that we were not going to achieve this vision by 2020. And one of the reasons is this is our financial problem. We've got a big budget deficit within the public sector in Scotland of almost £40 billion. And we have to be much more efficient in how we deliver care. And we firmly believe that the way we're going to do that is by driving forward the agenda of integration. By integrating our hospital and community healthcare services, which we did many years ago, that produced efficiency, but now we're integrating health and social care, bringing together all the key components and joining them up to make a coherent and comprehensive picture. Because our citizens do not care who delivers a service, just as long as that service is delivered to them of a good quality. Now, it has been possible to integrate health and social care in Scotland for the past 5 to 10 years, but it never happened. So our government has legislated, and it is now the law in Scotland that health and social care has to be integrated. And while we published our bill last year, and it is now in effect, we did an international review around the world to see what the key component and important successful criteria would be. And this is what the evidence told us. We need to plan for populations, not base our planning on the delivery structures that currently exist in the landscape. We must pool resources. That is pooling budgets, but also pooling people. We need to embed doctors and other clinicians and care professionals in the process of service planning. They need to be sitting around the table when we're making decisions about investment, as well, of course, in planning the provision of health and care. And very strong local leadership is fundamentally important for success. So we're using integration and the structures we're putting in place as a tool to understand the long-term demand and make sure that everyone has got a common understanding and perception of the world, what the challenges are and where the opportunities are. We need to understand the best approaches and methods for meeting that demand, but most importantly, we need to improve and modernise our services to achieve not simply a much nicer or pleasant experience, but better tangible outcomes. And we must do that through innovation. And innovation is not simply referring to technology, but it's talking about how we deliver service. So innovative service redesign is going to be key to success. And we must achieve best value. Now, clearly managing and facilitating the market in a climate of changing times is also very important. And we need to make sure we bring academics and the industry community with us on that journey, because it's really going to be key to work across all those boundaries in the future. So our integration agenda is really about these key things. It sets out the principles for integrating health and social care. We have nationally agreed outcomes for health and well-being. We have now got an integrated governance arrangement. We've got integrated and joint budgets, and we've got a single chief executive in each of our 32 localities who is accountable for the delivery of the integration agenda. And at that local level, strategic planning is carried out as well as locality planning. So that's the structural bit. But what I want to do is to link back to something you were talking about earlier, and that is the role of innovation and technology. I'm old enough to recognise what this type of building is. When I lecture to my medical students, they have no idea what this building is. This actually is a picture from 1965, and this is a bank. Clearly nowadays, most people do their banking in this way, either through machines on the walls outside those big buildings, or using mobile devices. Do any of you recognise what this is? This actually is a hospital waiting room from 1907, over 100 years ago. And this is a hospital waiting room in the United Kingdom in 2014. The only thing that is different is the floor coverings, the wall coverings, the lighting, and the fashion. Otherwise, it is very, very similar. Because I firmly believe this is where we are with the use of technology solutions when we apply it to servicing the needs of patients. What you see in the background of this picture is one of the early motor cars, and people were saying motor cars will never catch on. They're too noisy, they're not safe, they're not efficient. If we only put another 2 horses in the front of this bus and made the bus slightly bigger, everything is going to be all right. Are these the types of conversations you hear around your management tables? Are these the types of conversations that you engage with on a weekly or a monthly basis? They certainly inform some of my conversations, and we need to move the world forward. Because the reality is that in the UK, and I think it will be the same in Greece, the vast majority of healthcare transactions are done exactly the same way today as they were done in 1948. People go to see a doctor, people are sent to the hospital, and things are done unto them by others. Now, if you look at this statement from 1819, where it says, I'm extremely doubtful that the beneficial application required much time and gives a good bit of trouble both to the patient and the practitioner, this is people saying that the stethoscope would never catch on. And within 3 years, of course, in 1821, people could not do without it. But we've got the same problems today. So, what does this mean? What does integration mean for us? What does the use of technology underpinning integration mean for us? Is it going to be the white knight that is going to solve all our problems? Or is it going to be the white elephant that actually doesn't move us forward? But when we're planning for the future, let's just look at some of the facts. And I'm not going to tell you what the answer is. I just want you to think about what I'm going to talk about for the next 5 or 7 minutes. And over the next few days, see how that fits in with your work. Now, I don't expect you to read everything on this graph, but this basically talks about the deployment and use of telephones. If you look at the green line at the very bottom of the graph, this is the global number of fixed landline subscriptions around the world. And then if you look at the light blue line from 2000 that is going up right to the top of the graph, that is the number of mobile subscriptions. And in fact, we're now at the stage where there are almost more mobile subscriptions and mobile devices in the world than the population of the world in total. What does that mean for us in healthcare? Well, a lot of regions around the world are saying they need to talk about digital first. We need to use digital channels for interacting with our citizens. And that's absolutely fine. But what I would suggest to you is we need to be thinking about not digital first, but mobile first. Anything that we do in the development of technology solutions, we need to plan now for that solution being able to be deployed and used on mobile devices. Because that is our future. That is our world. But as well as that, we talked to the citizens of Scotland and we asked them what was important to them. And as a clinical doctor, I was surprised by 2 or 3 of the things they said. People in Scotland want to give something back to the communities they live in, but they find it difficult to know how to do that. They want to care for others, but they're often scared that rather than looking after someone, they will choose not to do it because they're scared they do something wrong and they harm the person. Now clearly the provision of reassurance and information and advice can overcome that. But the other thing is that they are time poor. They are often in full-time work, frail, vulnerable relatives live a significant distance away, and they find it difficult to provide care. They like the stories of how communities come together. For example, if there's a storm and there's been flooding, how communities will pool together and help each other out. But they don't want that just to happen for 2 or 3 or 4 weeks when there's a local emergency. They want that to be present all the time. And they want to share the knowledge and skills that they have with others. And they firmly believe that people are no longer as connected to their communities as they used to be, and they would like that connection to come back. And what I would like to suggest to you is that the appropriate use of technology as a way of better integrating people back into their own communities, be they geographical communities or be they virtual communities of care, is a really important way for us to think about delivering sustainable services for the future. Because what we're saying in Scotland is we're going to use technology to unlock the creativity, skills, knowledge and experience that each and every one of our citizens has within themselves in some way or another. Be it the homeless person on the street, through to the professor in his Mercedes driving to work. We need to create the opportunity where the willingness of communities to give things back to others within that community are harnessed. So rather than us always relying on expensive formal health and care services to provide solutions, we should empower communities to deliver a lot of those solutions themselves. And I firmly believe that the appropriate design and use of technology can help support that. Because we know that people want to take more responsibility for their own health. They want to do more for themselves. And long-term conditions management for diabetes, high blood pressure, chronic obstructive pulmonary disease are all things we know are amenable to home monitoring solutions. And I know across the regions in Greece that you are participating in European projects looking at these types of solutions. And they don't just empower patients to do more for themselves, they actually can make a significant difference. And this comes from the whole system demonstrator in the UK, which shows that if you've had an incident of acute heart failure within the past year, and you're put on standard monitoring and intervention, going to the outpatient clinic and consulting your doctor, the green line shows the mortality over the first year, the purple line, the pink line, shows the mortality over 1 year, where approximately 20 people will die over that year. However, if you're in a home monitoring solution where you're monitoring your own condition regularly at home, mortality is significantly reduced, statistically significantly reduced, and I know which group I would like to be in. Secondly, this is for diabetes. It shows the HbA1c control is significantly better if people are monitoring their own glucose at home and are able to access and view their own results. And also their compliance with treatment, both in terms of the diabetic medication, but also attending appointments for food screening, eye screening, and so on, are significantly improved if you're on a home health monitoring type of solution. Well, what do we do in health and care? We always make things too complicated. And as soon as we complicate things, people drop out, but also we incur significantly additional costs. Because you can never replace people with equipment. Constantly some systems are trying to do this. And that is fundamentally flawed. Because what we are saying in Scotland is that face-to-face care is the most important resource that any health and care system has. But what we are saying is we will use all digital channels available to us to service the needs of our citizens when it is safe and effective to do so, but most importantly, when it is appropriate to do so. But we will use these channels to make face-to-face care more available and more accessible to those that need it when they need it. And we're going to do that by using these devices. We're going to use mobile phones, we're going to use tablet computers, and we're also going to use digital television as the main way of interacting with our citizens. And we have a national delivery plan for digital services, and in Scotland we call them telehealth and telecare services. Don't worry about the name. Because the problems we have are never about the technology. They're always about the service redesign. So when you read in the literature about another case of home health monitoring where it doesn't work, it's not that the technology doesn't work, it's usually the service design has got some fundamental flaws in it. And we also have to make technology easy to understand and easy to use. I don't know if any of you have actually seen this. I'm an old person, and when I listen to the radio or the television and I'm told there's going to be 20 centimetres of snow, or maybe in your case 8 millimetres of rain, I'm not quite sure what that actually means in real terms. So in Boston in the USA, where they have a lot of snow in winter, they on their website have, can you still see your dog? And what you've got down at one end, you see the little dog, that's a Chihuahua, and at the other end you've got a Great Dane, and you can see how far the snow will come up your dog. So everyone has got a set record that they can understand how heavy the snow is going to be in Boston on the 27th of January. But we over-engineer and we redesign our web services, in particular for the public sector, in a way that is easy for us to understand as health and care professionals, but it's increasingly inaccessible for our citizens. Because we need to also recognise that no one stays the same in life. We all go through periods of being well, being unwell, being anxious, being happy, and we need to make sure that our service offerings reflect that. We need to make sure, particularly if we're going to use technology, that we use the right technology for the right conditions. But at the moment, we tend to use one solution for everything. And just like you can see here, it is never that one size fits all. So what does that really mean? Well, what I'm not suggesting, by the way, this is not my house. What I'm not suggesting is we turn very pleasant, homely community settings into intensive care units. So what I am suggesting is that we transfer care that is more appropriately, safely and effectively delivered by our own citizens who want to do more things for themselves into the community and allow them to do it, but support them in delivering those services. And that is where the service wraparound and the service design comes in. Now, industry is a way ahead of us. There are now 97,000 plus mobile health apps and increasing. Most of them at the moment are still round about fitness, but now 30% are targeting health professionals. Some are exceptionally good, some are less so. And we as healthcare systems have to recognise this and recognise this as increasingly growing, and we have to decide how we're going to interact with this. How do we quality assure things? How do we make sure they're safe to use? How are we going to support professionals to use these appropriately? And how are we going to signpost our citizens to those that are safe and effective? And they cover everything now, from dementia health to breast cancer management to healthy eating, you name it. There are apps out there for it. So this is an example of a public service app we've devised in Scotland. This doesn't look like your standard healthcare app. This was designed with 30,000 of our citizens. And this is about how people volunteer to help others within their own community. At the same time, it allows them to monitor their own long-term health conditions. It also allows them to have video consultations with a family doctor or the hospital, if that is available to them. And it also signposts them to resources in their communities that can help them with their health needs. For example, how to access rehabilitation after a heart attack, how to get together in lunch clubs and social clubs to combat anxiety and depression. This is actually supported by the formal health service in Scotland, but it's designed by citizens for citizens. Because the way I and we perceive the future is we need to give people more choice. Technology can do that. We need to give people more control, not simply over their lives, but over their health and care management. We need to improve the connectedness that people feel towards their own communities. We can use technology to collaborate better between healthcare professionals, nursing colleagues, between hospital and community health services, between health and social care. But most importantly, we need to recognise everyone has a contribution to make. That includes the patient and their family. And remember what I said at the start, this needs to be all about community. But we always delay doing things. We always wait for the next thing to come along and think that someone else is going to solve the problem. That never happens. So what I would suggest to you is, we need to make the decisions, and we need to have the courage of our convictions, and we need to move forward now. We're running out of time, and we owe it not just to our citizens, but we owe it to ourselves and to our families. And for me, it's all about collaboration. It's about collaboration between the patient and the formal health and care system, collaboration between their carers, their families, and healthcare professionals, collaborations between governments, between academic institutions, public sector health and care providers, and industry, all working together. But most importantly, it's about collaboration between like-minded people and collaboration across Europe. That's why, as one or two of you will know in the audience, Scotland has already been in discussions with colleagues in Greece about how we can collaborate more effectively together. Because in the past, when there was money in the system, we always thought we had to own our own problem and build our own solutions. We don't have the money to do that. We don't have the time to do that. We need to learn from each other. We need to learn together. We need to collaborate and cooperate, and I look forward to continuing to collaborate and cooperate with colleagues in Greece, and hopefully the next time someone may invite me over to Athens again in 2016, and I can come in person and we can continue this conversation. Thank you very much indeed for listening.